So Naba will be presenting the case as everybody does during our ward round. Person will first announce and then we'll go live because currently we are, I think, on demo mode, and when they go live, they change the mode. We don't have to do anything. So Saurabh,
So shall we start, sir?
yeah, start.
Yeah, thank you so much, sir. Good afternoon, sir, and good afternoon, ma'am. Good afternoon, all attendees to being here. I am Ms. Sharma, host for this session. I request Dr. Samir Jog, sir, to start this session. Thank you, and over to you, sir.
Thank you. So in continuation with our case presentation, today will be our fourth case presentation by one of our colleague, Dr. Naba from Escorts, Fortis Escorts. She has prepared a nice case on cardiac arrest and post-cardiac arrest management. It is a very important topic for all of us because in a large ICU catering 40-50 patients, at any given point of time, you will have at least one such patient who has got either in hospital arrest or out of hospital arrest, and our team is managing that peri-arrest scenario. So it's a very important topic for discussion. So as usual, Naba will be presenting the case which she had managed in her ICU, and my colleagues Dr. Gauri from Jupiter Hospital Thane and Dr. Jitin Sharma from BL Kapoor Delhi will be moderators or examiners for Naba's case. And as usual, they will be asking very difficult and tough questions. I have already told them to ask the questions because this is a mock exam and this is not a simple post diploma or IDCC exam. This is a DRNB critical care final exam. So the level of difficulty will be definitely high as possible. Okay, so we should start with this case. I will hand over to Naba for presenting her case, and Gauri and Jitin will be asking questions.
Good afternoon. Okay. Should I start, sir?
Yes.
Okay. Good afternoon, everyone. Today I am presenting a case on post-cardiac arrest scenario. So, a 3-year-old male patient presented to the ER with a history of unresponsiveness for the last 45 minutes. He was in a market at the time when it happened, where bystanders had witnessed it and they started chest compressions and brought him to the hospital. In the ER on examination, patient's bilateral carotids were not palpable, his BP was not recordable, and the ECG on the monitor was showing asystole. Immediately, CPR was started as per the latest ACLS guideline. After CPR 30 minutes, ROSC was achieved. Then, meanwhile, patient was intubated and central venous access with a triple lumen catheter and arterial catheters were inserted. On getting the ECG after ROSC.
Wait.
Okay.
Yeah. What was the temperature of this patient? And it is important.
Okay. So initially, sir, the temperature of the patient was afebrile. It was normothermia. There was no hypothermia or hyperthermia. It was a normal temperature around.
And why it is important in this scenario?
Because the patient could have a hypothermic arrest, and there was a prolonged duration of unresponsiveness out of hospital. Also, since the patient was in the market, it could also be a case of hyperthermic arrest as well. So both the scenarios should be ruled out, both hypothermia and hyperthermia.
Can you tell any one mechanism how hyperthermia will cause cardiac arrest? Any one mechanism? So, like, sir, in heat stroke or any medication. Yeah, but before heat stroke, before cardiac arrest, lot many things will happen. Directly cardiac arrest is not possible.
Okay, so because of heat stroke, patient can have like electrolyte imbalances as well. Patient can have muscle, basically, he can have hyperkalemia because of
yes.
They can be severe
patient can be dehydrated, and also muscle lysis can lead to increased potassium, and it can lead to hyperkalemic arrest.
But we are more interested in hypothermia because why?
Yeah. Because hypothermia is one scenario where patient, when they arrive to us, it may look like patient is unresponsive and is in arrest, but on achieving normothermia, patient are like, it has been observed that patient survive, and even despite having a prolonged duration of unresponsiveness.
Okay, move ahead.
Okay, so on getting the ECG, actually the ECG that was done, that immediately was in the crash card, so I could not like present it here. But the initial ECG after ROSC showed complete heart block, after which immediately the cardiologist had inserted a temporary pacemaker through the right internal jugular vein under 2D echo guidance in the ER itself, and this was the ECG that was taken right after insertion of the temporary pacemaker. So on going to the past history, patient was diagnosed with second degree heart block 1 month before the presentation, and he was advised permanent pacemaker insertion by the cardiologist. But the patient had refused, and he did not undergo any treatment. He was also a known case of hypertension on tablet telmisartan 40 milligram. He takes once daily. Apart from this, the family members gave no other significant history. On elaborating his personal history, he was found to be a chronic smoker for the past 20 years, smokes 2 to 3 cigarettes per day. He does not consume alcohol. He consumes non-vegetarian diet, has no documented history of allergy to any medications. His family history was also found to be non-insignificant, where his parents were diabetic and hypertensive.
Wait, what are types of second degree heart block?
We have type 1, which is Mobitz type 1, also known as Wenckebach heart block, where then we have type 2. It can be of basically we have first degree, secondary, and third degree heart block. In second degree, we have type 1, that is type 1 Mobitz and Wenckebach, type 2, and then a high degree. And for third degree, we have complete heart block.
Nabha, when the question is asked, what are the types of type second degree heart block, the answer should be quite precise.
Yeah.
Yeah, don't beat around the bush of first degree heart block, third degree heart block. My question was quite precise, and this exactly happens in examination. When examiner asks a precise question, you should give a precise answer pertaining to that question and don't beat around the bush. Am I right?
Yes, sir. Should I say again?
Yes.
Okay. So second degree heart block has type 1, which is also known as Wenckebach heart block, type 2, and then high degree. In type 1 or Wenckebach, there is a progressive prolongation of PR interval, ultimately leading to a drop beat, where one P wave is not followed by a QRS wave. Whereas in type 2, Mobitz type 2, we have there is no progressive prolongation, but the P waves are not getting conducted to the following QRS waves. So more than, if there are more two P waves not getting conducted, it is the type 2 of the second degree heart block. And if it's more than two progressive P waves are not getting conducted, leading to a QRS, then it is high degree type 2 AV block, second degree AV block.
Okay, go ahead. Anything, Gauri and Jitin, you want to ask?
Just so now we know about the cause of cardiac arrest in these patients.
Yes.
So would you like to have any further history regarding his, possible other causes apart from this that might have led to this? Just because there's a heart block.
I would like to know the patient could also, like, the most common cause of cardiac arrest are found to be coronary artery disease related, and also the patient has a history of chronic smoking. He's a known hypertensive. I would ask about any previous history of myocardial infarction, any coronary artery disease documented by any echo or any coronary angiography done in the past. Also, since, as we already mentioned, the patient had a history of being out in the market, we have to rule out any environmental cause of hyperthermia. And again, in any history of medications, any history of structural heart disease documented, commonly cardiomyopathy, hypertrophic cardiomyopathy. And so apart from the cardiac causes, I would also like to rule out other causes, like if the patient had any history of any pneumonia or any background history of COPD, asthma, or any high risk behavior like any substance abuse history, then any medication history. Since the patient was already a patient of heart block, was he taking any anti-arrhythmic medications or any medications? Then
Like basically what you want to know from the history is that it might give us some kind of a clue to the cause of
cause of
cardiac
cardiac
arrest.
arrest,
Okay.
yeah.
So that is very important part, because just doing a CPR doesn't mean we need to have to look at the cause of the cardiac arrest as well simultaneously. So in that way, history is very important. So at the same time, can there be any particular signs you can look in a patient which may direct you the cause of, the cardiac arrest as well?
Signs
I'm just remembering a quick examination of
pertaining to this. Okay.
not talking about this one, just in general. I mean,
Okay,
just
we can start with our general examination. If the patient has any pallor, it could be because of some hemorrhagic shock. Patient could have any internal bleed. If the patient has edema, it could be because of either heart failure or some uh, chronic kidney disease, but leading to fluid overload, pulmonary edema. Then if the patient has a icterus present, could be because of any acute liver failure or acute on chronic liver failure. If the patient has ascites, that could also lead to either any cardiorenal failure or even is acute on chronic liver failure. Then
okay, what I want to say is that just before you're starting with your CPI, simultaneously you need to have a good history. Somebody needs to collect a good history, and one person should have a quick general examination as well,
yes, yes.
right? Just because in this case your patient landed up in already being in CPR, so we'll continue the CPR, but one member of the team will actually try and look for the cause. Try and look for physical signs if they're present. Maybe there's a history of some kind of toxin ingestion, something like that. So they should go parallel in hand. Okay, so. And again, after that, I need to move to, I think, the CPR part. I think we need to discuss few points regarding the CPR. So, just this patient presented you initially in asystole, you said, right?
Yes, sir.
So, how does that differentiate your initial management in terms of your CPR compared to a shockable rhythm? So, what is going to be a priority here?
Okay, first we need to differentiate what kind of a rhythm the patient has. Is it a shockable and non-shockable? If it is a non-shockable rhythm, which could be either asystole or any pulses electrical activity, then first along with starting with chest compression, we'll start give our injection adrenaline immediately. And if it is a non-shockable rhythm, then we'll start with the chest compression and defibrillation, and then later we'll add our injection adrenaline.
Right. So,
What are the shockable rhythms?
So, it is a ventricular fibrillation and pulseless ventricular tachycardia.
right. So the emphasis is that if the patient is in a shockable rhythm, then the defibrillation or the shock becomes the priority here,
Yes.
isn't it?
Yes.
And when it's a non-shockable rhythm, then you have to give epinephrine as early as possible, right?
Yes.
So just going a bit on a different track, just because your patient presented to you, maybe the patient might not have an IV access. The patient might not have an IV access. So do you have any alternatives? Supposedly you cannot find one. So in a case of arrest situation, can you do something else?
Yes, sir. As per the ACLS guidelines, we can give medications through intraosseous access as well.
Okay, fine. Fine. So just as you move ahead in your CPR, I would like to know, because it's very important. It's not just the duration which of CPR that will account for the outcome, but it's also the quality of CPR. So how can you? I mean, what do you want to talk about high quality CPR? How you define a high quality, a good CPR?
Okay. The chest compression should have it should be of 100 to 120 per minute. It should have adequate depth of 2 inches or 5 centimeter with adequate chest recoil, and it should be in a hard surface, and there should not be like the ratio of chest compression to ventilation should be 30:2. The ventilation should not be more than 1 second, and also the time of interruption should not be more than 10 seconds, even for checking pulse and everything. And there should be change of the compressors as soon as they are in fatigue, or after 2 minutes of chest compression. And,
Right. Anything you know about chest compression fraction?
yes, so chest compression fraction is the total amount of chest compression we do over a CPR cycle. It should be more than 60% of the
More than 80%. Okay,
sorry,
so the idea is
80%,
basically
and
to have minimal interruptions, because they
yeah,
say when you start your chest compression in one cycle, is you do 30 compressions. Okay, so just around like 10 to 15 compression, your brain gets to start perfuse. So if you have a break at that point in time, so that will hamper the perfusion to the brain. Okay, so this is the idea of high quality CPR, right? So
Thinking in advanced airway, if you have an
yeah,
advanced airway, one more parameter for high quality CPR.
yes,
yeah.
if we have a advanced airway place, then 6 breaths every 6 minutes we need to keep 1 breath, so 10 to 12 breaths per minute.
No, but can you monitor something?
Yeah, we can. Sorry, we can monitor end-tidal carbon dioxide value with our when we have an advanced airway placed, and we can monitor the quality of CPR if a patient's EtCO2 is less than 10 to 20 mm of Hg. Then it means we need to improve the quality of our CPR, the compression.
Right. That's good. Okay. So I think we all were very versed with the ACL's protocol and how do we CPR. This is our daily business, right? But just want to highlight a few key points, like what is the role of calcium in particular?
Calcium, as per in the per se ACLS protocol, there is no mention of calcium. But if we have a hyperkalemic arrest, we need to give injection calcium in that scenario.
Right. And any role of any antiarrhythmic medications?
Yes. So if we have a shockable rhythm after giving defibrillation for 2 cycles and then giving injection adrenaline, if the patient is still having VT or VF, then we can go ahead with injection amiodarone and or injection lignocaine.
Fine. I think we should move ahead. Dr. Gauri, do you want to ask something?
Yeah, fair enough.
Yeah, please, let's move forward.
So coming to the course during the hospital stay, patient was shifted to ICU for further management. On arrival in the ICU, the clinical examination revealed that the patient's GCS was E1 VT M1. Bilateral pupils were reactive to light. Heart rate was 70 beats per minute, and it was TPI dependent. BP was 160 by 95 millimeter of mercury without any vasopressors. Saturation was 96%, and patient afebrile. The temperature was normothermic. Chest revealed bilateral air entry, and the cardiac sounds were present on auscultation. On POCUS, the patient's bilateral lung field revealed A profile with few B lines at the basis. 2D echo, at the bedside 2D echo revealed an ejection fraction of 60% on eyeballing method, and there were no regional wall motion abnormalities seen. And in general, in systemic examination finding, no significant abnormalities were observed. Then all relevant investigations were sent and treatment was started as per our standard ICU protocol.
Okay. So now we have entered into the post-ROSC care. Okay.
Yes.
So the ROSC has been achieved. Now patient has been shifted to ICU. Now, what should be the priorities? Now you have like, okay, you have done your primary examination. What should be priorities in this kind of situation? What
First,
are
we
the
need
objectives of your post cardiac arrest or post cardiac arrest care?
mainly there are two objectives. One is first and foremost, we need to identify the cause of arrest and try to reverse the cause. And after that, we need to do damage control and prevent any worsening of the organ damage, especially the brain.
Okay. Okay, so even in your case, you say that okay, your patient had a heart block, right?
Yes.
But were there any signs of any underlying ischemia? Would you like to go for any cardiac evaluation in this patient?
Ideally, sir, we should, as per the guidelines, we should go for an emergent coronary angiogram. In our case, we did not go for it because our cardiologist we had a discussion and they did not want to go ahead. They wanted to go with the electrical stabilization, but we should.
So, what my next question is very obvious. What are the indications for a coronary angiogram after cardiac arrest? Like, should all patients be subjected to angiography?
Since coronary artery disease is one of the most common causes of cardiac arrest, uh, ideally, like it is reasonable for all patients who are comatose after arrest to undergo, but the class 1 indication is any patient with ST elevation MI on the ECG or suspected MI need to undergo cutaneous coronary intervention, and also reasonable in cases where even if there is no evidence STEMI on ECG, if the patient is electrically or hemodynamically unstable, irrespective of the GCS, they should undergo. It's reasonable as
Right. So,
per the
apart from
guidelines.
ST elevation, if your patient has a shock, electrical instability, or maybe have signs of ongoing ischemia or myocardial damage, these patients, it's reasonable to get a CT angiography done, right? As you rightly said, this cardiac ischemia is probably the most common cause underlying cardiac arrest, right? So, apart from CAG, would you like to have any other investigation that can help you detect the cause of your arrest
Okay.
in the patient?
We will start with initially we got an ECG done, then we need to get a bedside RBS blood sugar monitoring done, then baseline ABG, then all the routine investigations, lab investigations of complete blood count, electrolytes, kidney function, liver function, even our cardiac enzymes, then also a chest X-ray. Basically, at least this should be done in all the patients. And if you're suspecting from the history of any intoxication, then maybe tox screen.
Okay, fine.
Yeah, one more thing about the coronary artery disease. Is there any study which mentions the incidence of coronary artery disease in any of this patient in
Sorry,
hospital arrest or out of hospital arrest?
I couldn't hear
The
that.
evidence of coronary artery disease in this. Hello, can you hear me?
Yes, now I can hear.
Yeah. So the evidence of coronary artery disease in cardiac arrest patient, whether it is in hospital or out of hospital, are you aware of it?
Ma'am, the incidence of in hospital and out hospital. That part got again.
Uh,
Hello. Hello.
Hello, am I better audible?
Yes, ma'am. Oh, that part was not audible. In hospital, out of hospital. What was the question?
Incidence of coronary artery disease.
Incidence of. The in hospital cardiac arrest is around 23% and out of hospital around 9%.
No, it's very huge. It's around 60 to 70% of the evidence of coronary artery disease. Yeah.
Okay. Sorry, ma'am. So I got the question wrong. I thought. Okay, I'm sorry.
Yes.
Okay, no, let's move forward. Okay,
Okay.
Naba, can you hear us?
Yes.
Let's move forward, please, with your case, right?
So on getting the investigations done, the 2D echo proper was revealed again an LVEF of 60 to 65% without any regional wall motion abnormality. There was a concentric LVH seen and grade 2 diastolic dysfunction was seen. The lab investigations revealed a hemoglobin of 13.6, TLC of 29,000, platelets of 2,42,000. The PT INR were grossly normal. The bun was 32. Creatinine was raised. It was 2. Sodium, potassium were in the normal range. HbA1c was normal. The LFT showed increased transaminases and SAB-GGT, and the albumin, bilirubin levels were in the normal range. Chest X-ray did not reveal any gross abnormality.
Okay. So, what do you think is the possible cause of this elevation of transaminases in this patient?
So because of the prolonged ischemia time, there is ischemic changes in almost like all the organs. So ischemic hepatitis is one of the leading cause of transaminases post cardiac arrest.
Fine, I think let's move forward from it.
Then coming to the day one management, the patient was started on lung protective mechanical ventilation on volume control mode, and maintaining the rate were adjusted with maintaining eucapnia, and FiO2 was titrated with keeping a saturation of 94 to 98%. Then we started targeted temperature management. Sedation was
Okay.
Sedation was started with injection fentanyl infusion. Enteral feed was started within the 24 hours via a nasogastric tube. Patient was started on injection piperacillin tazobactam, and DVT prophylaxis was done with intermittent pneumatic compression device.
Right. So this is day one, and your patient is still comatose after ROSC, right? So this is about the management of post cardiac arrest patient. Okay. So you discussed about target temperature management. So what is the current status of temperature management in terms of post cardiac arrest patient? Just can you?
Yes. So the recent AHA guidelines suggest keeping a targeted temperature of 32 to 36 degree centigrade for 20 at least 24 hours post ROSC. As per the trials, there has been a shift of normothermia as compared to hypothermia in the previous trials. So right now, it
Okay.
is recommended to keep a temperature of 32 to 36 degree for 24 hours.
Okay, that is as per the AHA CLS thing, right? But I think the concept is we started from therapeutic hypothermia, is moved on to target temperature management, but now the trend is towards temperature
Yes,
control, I guess.
normothermia.
So
Yeah.
yeah, the update which says that you maintain a temperature of between 32 to 37.5.
Yes.
So they have not specified any specific target as compared to, I mean, in terms of temperature management per se. So they say if patient is spontaneously hypothermic, right?
No need
So this would be a
to.
temperature 33 to 37.5, right? And if your patient is in a normothermia, then you continue with the normothermia as well. But still, I mean, this is not followed across the world. Most of the institutions, they have their own protocols. People are using TTM as well, even today, even after the updates in the last guidelines, 23 actually. So, is your this are you aware of any trials based why this we have reached to this consensus? Like how it all started with these trials, important trials regarding the temperature management.
Yes, the first landmark trial that started was from the Bernard trial in 2001. So there, basically, what they did was they compared hypothermia with uh, basically it was hypothermia. The control, the intervention was hypothermia compared to no temperature management in out of hospital cardiac arrest in shockable rhythm patient, and they found that there was improved neurological outcome with hypothermia. Same with the HACA trial, where they compared therapeutic hypothermia with no temperature management. There also they found improved neurological outcome and mortality benefit. But after that, there came the TTM1 trial, which found where they compared 33 degrees centigrade with 36 degrees centigrade, and their primary outcome was to assess the nine this thing 90-day mortality and also 6-month neurological outcome, where they did not see any benefit with the 33-degree centigrade group. After that, again, we had one hyperion trial where this was the only trial where the non-shockable rhythm patients were taken into the study. And here they compared again 33 with normothermia. Here they found improved neurological outcome with the hypothermia group. Then the last one, we had the TTM2 trial, where they compared 33 degrees centigrade with normothermia. There was basically, if the patient had a temperature above 37.8, they instituted cooling blankets to keep a normothermic temperature. So here also they did not find any improvement in outcome in terms of either mortality or neurological outcome. In fact, they saw that in the hypothermia group, there was increased incidence of arrhythmia and hemodynamic instability. So all this has now led to institution of normothermia rather than hypothermia in
Right,
targeted
you
temperature
have
management.
already highlighted the problems associated with hypothermia that we faced when we used to, cool the patients to lower levels. So now they're saying that maybe just keep them normothermic. And if they are spontaneously hypothermic, then what would be the rate of rewarming suggested now?
It should be done at the rate of 0.5 to 0.25 to zero point 0.5 degrees centigrade per hour.
Right. So it could be active or passive, but slow rewarming if a patient is
Slow.
spontaneously
Yes.
hypothermic. So that is advice, right? So your patient was on TTM, right?
Yes, sir.
So would you continue with just by sedation only? Would you like to add neuromuscular blockade also if your patient is
Yeah.
on
One more
TTM?
thing, why you want to give sedation to this patient?
Right.
Yeah.
Patient is already comatose on venti. Why you want?
Yeah. It One thing is, as for all critically ill patient, it aids in the comfort with ventilator, mechanical ventilator. And the more prominent indication in targeted temperature management is because the patient can have shivering, which will be counterproductive, as it can increase the metabolic rate of the patient, and it will be again counterproductive. So we need to suppress the shivering mechanism. For that, we need to sedate. And as sir already asked, if the sedation is not adequately suppressing the shivering, then we might have to give bolus doses of neuromuscular blockers.
Okay. Anything else other drug than fentanyl and neuromuscular block before?
We can give tramadol as well, and there's a role of pethidine as well. Then
Okay.
Okay, that's great. Can you highlight any problem that is associated with the using these sedative drugs as apart and also neuromuscular blockade?
yeah, as the patient is already hypothermic, the duration of action might get prolonged of the drugs. And here it is particularly important because it might interfere as a confounding factor in neuroprognostication.
Fine. And again, also the problem is that if the patient is having a seizure, then probably you
We
might
might miss out.
miss it. You miss
Yeah.
out on that. So that is one more reason. But we have compared intermittent with the infusion of neuromuscular blockade, and it's been shown that somehow the outcome was better when the infusions were done. So if you're doing targeted temperature management, then probably if you decide on that, you may continue with the infusion, right? But I mean, there's still juries out there, so just to decide on that. And there's another important point here regarding the antibiotic. So, is there any role of prophylactic antibiotic in every cardiac arrest patient, or is there any specific
Uh,
reason in your case?
because the patient has a prolonged duration of unresponsiveness, there could be chance of aspiration while the patient was unresponsive. Also, since the patient was in the ER, we had to put invasive catheters, the PPI, and the central line, arterial line. Those could also make the patient prone to get hospital-acquired infection. So, and also since the patient is hypothermia, it increases the chance of infection, especially ventilator associated pneumonia.
Okay. But I think the one of the reasons in your case probably because of hypothermia, there is increased chance of pneumonia. Probably that might be an indication that's also in the guidelines. But in general, there's no indication per se until unless you have some sign of infection somewhere. You can't presume that you might patient aspirate. If you have on a patch on an X-ray, probably yes, this is there. Okay. Apart from that, I think you have done the usual measurement that you have started DVT prophylaxis, started on the feeds as well. So let's move forward, I guess, Dr. Gauri.
Yeah.
Yeah, please.
On day 2, the NCCT head was done after the first 24 hours, which revealed no abnormality. Then after that, patient was started on anticoagulation with unfractionated heparin, and the targeted temperature management was continued. After the completion of 24 hours, there was gradual rewarming done at the rate of 0.25 to 0.5 degrees centigrade per hour. Sedation was stopped. Then after sedation was stopped, we had assessed the patient's GCS, and the patient was still unresponsive, but the bilateral pupils were showing reaction to light. Neurology consultant was taken at this point, and the neurologist advised an EEG, which showed generalized slowing of background activity with intermittent bilateral frontal slow wave discharges. And as per the neurologist opinion, the patient was started on injection levetiracetam.
Okay, here's another important point. What are the guidelines regarding initiation of anti-epileptics post cardiac arrest? Are they prophylactically given, or do you need to have any evidence or any specific indications here?
There is no guideline regarding prophylactic anti-epileptics post cardiac arrest, but if we have, like in a normal patient, if we have any evidence of seizure or status epilepticus, then we might have to add anti-epileptics or any EEG findings.
Okay. So what anti-epileptic? I mean, you have used the levetiracetam. Definitely, that's fine.
Yes.
But what are the
The AHA guidelines recommend the drug of choice here as injection levetiracetam and injection sodium valproate. But there are studies which say that we can use normal anti-epileptics as the indications are for regular seizure cases.
basically, they mentioned that you should avoid the sedative
Yeah.
base basically. So non-sedating anti-epileptics can be given. So that is, I think, this is advice, right?
Should I go ahead?
Yeah, please carry forward.
So on day 3rd and 4th, again the routine ICU care were continued. Spontaneous breathing trial was applied after the patient was adequately rewarmed and was normothermic. Care was taken to avoid hyperthermia for the next 48 hours after rewarming, but patient was still unresponsive. Bilateral pupils were reactive. Then on day 4, NCCT head was repeated, which now suggested of hypoxic changes. And we repeated the EEG, and it showed diffuse slowing. So this was the NCCT had done on day 4.
Okay. So now you know that your patient has suffered hypoxic injury. So the more important point is like neuroprognostication. So what is the timing actually when you do the neuroprognostication, and what are the signs you look for or investigations you want to do for prognostication regarding the outcome.
So if we do not go for targeted temperature management, we can do neuroprognostication 72 hours after ROSC. And if you're doing targeted temperature management, then after the 24 hours of targeted temperature management and rewarming, after the patient is rewarmed, then after the patient has achieved normothermia, from that point onwards, 72 hours gap we need to wait, and then we can start with our neuroprognostication. And it can be done under the following headings. It can be clinical examination, like the way we do GCS. We'll basically look at the motor response of the patient, and we'll look at the pupillary reflex, corneal reflex, then all the brainstem reflexes. Then we start doing our neurology marker test. Here we can do our N and like neuron specific enolase test is done at 48 and 72 hours, and if it has high level, then it shows poor prognosis. Usually a value of 60 microgram per liter is taken. Above that, if we have any value, then it might show poor outcome. Then apart from these, we have electro neurological monitoring via EEG and also SSEP. So in SSEP, if there is any absent response of SSEP N20 at 72 hours, then that also shows poor prognosis. And in EEG, if within 24 hours we have a very high malignant pattern of EEG, then it also tells us about a grave prognosis. Apart from
So
that,
it's a 24 hours EEG pattern monitoring you want to do, or it's
if a institution has a provision of continuous EEG monitoring, then it should be done. Otherwise, if it is not available, then ideally at least once a day of EEG should be done. And apart from these, we have our neurological imaging. The NCCT head is given as it should be done within 24 hours, and MRI brain can be done from after 24 hours to 72 hours and or later. Then also
Okay. Sorry. So why don't you want to do this neuroprognostication prior to 72 hours?
Because this hypoxic brain damage, it takes a longer time to, like, at least 5 days to like be evident to manifest fully. Also, since we had given targeted temperature management, and we had given all these sedatives and paralytics, all these confounding factors should be like removed from the patient's and also patient should be adequately stabilized, so that basically we need to rule out all the confounding factors and wait for the hypoxic changes to manifest uh, properly. Because if we do earlier than that, then we may have a falsely we may like negatively prognosticate the patient's condition.
Okay, that actually highlights the role of sedation and neuromuscular blockade when you're post cardiac care or arrest care. Because if you're not doing a target temperature management, then perhaps you should avoid using sedatives, because your patient is already comatose, isn't it?
Yes, sir.
So that actually is very helpful. You don't need to use long acting drugs. You need to have very short acting drugs if at all required. So that it may actually help removing all these confounding factors that will be there. But at least 72 hours gap should be there before you actually talk to the families regarding the long-term outcome of the patient. Okay. I think we can move forward.
are there any scales for neuroprognostication?
Yes, there is one. I forgot. It starts with
Cerebral performance
cerebral
category.
perfusion category, and also there's one Philadelphia. I forgot the
Modified Rankin
Modified
scale.
Modified
ranking.
Rankin scale, cerebral performance category. Cerebral performance category, basically, it has 5 scores. So the scale 1, it says the patient is alert, conscious, and living normally. Grade 2 means it has moderate cerebral disability. Grade 3 means patient has severe neurological disability. Grade 4, coma, and grade 5, death. And
Right.
Yeah, we can move ahead.
on day 5 and 6, patient remained unconscious. GCS was E1, VT, M2. The bilateral pupils were reactive. Bilateral corneal reflex was also present. GAV reflex was present. By now, after 72 hours of post-TTM, we had a multidisciplinary meeting with the patient's relative. Hello? So, patient's prognosis was explained to the relatives. The patient
Okay.
was the patient was still TPI dependent. So patients after explaining the patient's prognosis, the relatives wanted to go ahead with the definitive management for the heart block, and so the cardiologist had a permanent pacemaker inserted on day 5. And as per their protocol, injection ticoplanin was added. Then on day 6, okay.
No, I just want to know, because this, I think, is the most important part, because families want to know about the neurological outcome, because they always tend to ask, "Aage kya hoga?"
Yes.
How they're going to wake up. So how you address this issue from their side?
So right now,
Suppose we are the relatives of that patient, So you got to
Exactly.
tell
Just try
us
and
in the
explain us.
same way how.
okay. So should I
So our
like talk?
relative is hypox.
Hello?
Yeah, you
Yeah,
can
can you
ask
hear?
us whatever.
So I'll start with my introduction, and then I'll try to build a rapport and try to reply to all their answers. I'll listen to all their questions and answer empathetically. I'll try to explain the current condition of the patient and also the future prognosis. Basically, since patient is a hypoxic ischemic encephalopathy patient, so I'll have to explain that patient may or may not recover, and even if the patient shows recovery, it could be very prolonged. It could take months to years, and even after that, patient could be severely disabled. Patient can have impairment, especially visual or speech impairment, cognitive disabilities. Patient can be bedridden. So, I'll let them know about all the like scenarios that could happen, and also there could be like psychological disturbances. Patient can be depressed, anxious. Patient can be there could be occupational disability as well. Patient may not be able to continue with his occupation, and apart like even despite that, if they want to go ahead with the treatment, then we'll have to like go ahead and
Okay. I think so. That's the important point, that you have to make a very good rapport with the family as soon as you interact with these patients. You have to have a daily discussion, right? You don't actually prognosticate them, but try and build a rapport so that when the time comes, you have some kind of rapport to actually discuss that issue. And you have to be very firm and very true to explain to them that the chances of recovery are poor, definitely. And you have to be blunt though at times, but you have to tell them the clear picture. Okay, so let's move ahead. Let's see how it goes.
Yeah,
on
and the
the
patient can be totally dependent. We'll have indwellers. They got to take care long for them, nursing care,
social
everything.
financial burden. Yeah,
The cost involved in that prolonged care.
yes.
Yeah.
Then on day 6, the patient was tracheostomized after taking consent from the relatives at the bedside. On day 7 to 11, the course of stay. So on day 8, the patient had developed new onset fever with hypotension, for which vasopressors were started. Relevant cultures were sent and antibiotics were escalated from injection piperacillin tazobactam to injection doripenem. Endotracheal aspirate culture revealed carbapenem Acinetobacter baumannii. Now the antibiotics were modified with injection polymyxin B and nebulized colistin were also added. Then by day 10, patient began improving. Vasopressors were tapered off. Weaning trials were continued, and then patient was eventually planned for PEG, and for which gastroenterology consultation was done. But the patient's attendant took leave against medical advice on day 11, citing financial reasons.
Okay, this basically highlights all the problems that we face once the patient has, all the issues in the long-term ICU stay. So there may be infection, all the complications that may follow, right? So apart from that, I think that covers a few very important points also, all the important points, I guess. So any other, just apart from your patient, I mean, just want to address the issue that maybe in some patients who have after a cardiac arrest, they may be a candidate for organ donation. So you may actually be in appropriate setting, appropriate patient probably may start, discussing with the family regarding organ donation as well, right? So that is one other issue. Dr. Gauri, do you want to ask something regarding?
Yeah, so how long as a relative I'm asking, as one thing was tracheostomy. So as a relative, I want to know, can we not remove the tube? Why we want a tracheostomy? How will we manage the patient as a relative?
Okay, ma'am, since the patient is currently ventilator dependent, we cannot remove this tube. If we remove the tube, patient will not able to maintain his breathing, his respiration, and may collapse and have a cardiac arrest. So to maintain his life right now, we have to continue with the tube.
Our patient is not breathing as of now.
Sorry, ma'am.
Patient is not breathing as of now?
Okay, a patient is breathing, but he is not able to maintain his breathing completely on his own. He needs this ventilator support right now. That's why
So
we
by
are.
when the ventilator will be out as a relative, I want to know.
For that, again, we have to. We cannot definitely say, but we have to continue with this as of now. But what we can do is we can start weaning the patient. We can start taking him we can taper the support gradually if he maintains it. And since this tube can again increase your chances of getting infection, and there are other like patient can be uncomfortable. There are
So how
more
do we
chances.
end this, doctor? I mean, this will continue, looks like. लंबा time लगने वाला है. So how do we end this? Is there any way out, or we just have to continue on ventilator, giving antibiotics? Or there is a time frame to look at?
What we usually do is, ma'am, we usually we give the patient chance to wean off, and when we put the patient from ventilator from the this particular tube to the tracheostomy tube, the patient can have a better chance of at least pulmonary recovery. Patient can if the patient has a recovery, then patient can be started on oral feed. Patient can be maybe taken off the ventilator and maintained on initially on oxygen, and then eventually patient can be kept on room air, but that could take a long time.
So what I'm
I
discussing
don't
is
have any definite answer right now.
end of life care. How do you discuss with relatives the end of life care? I mean, the patient is not going to wake up. Patient will be with the tubes. So how do you talk to the relatives about it?
If the basically we first need to find out if the patient has any advanced medical directive already, like he has. If the patient has, then we need to go according to that. Otherwise, we'll have to have a discussion with the relatives regarding the patient's, if the patient was alive, how would they have wished to go ahead? If they would continue going on and like this, or they would have wanted to end the treatment. Then if the patient's relatives give the answer like the patient would have wanted to end it, or there was an advanced medical directive that says the patient does not want any continuation of treatment, then we can start with the end of life care this thing cycle.
So we
So
maintain
basically,
the dignity of the patient. We allow them, whatever the will was the patient. We continue feeding, taking the nursing care, whatever possible. But if the patient deteriorates, they wish, they don't want to be aggressive, we respect their decision.
yes.
It's fine. If they want to be shifted to the ward, if the patient is stable, they don't want to come back to the ICU, if there's deterioration, we allow that also. Doing that. If they have some religious kind of
We
activity they
allow.
want to do, we allow that also. Right? Anything else, Dr. Jitin?
I think we covered most of the topic. There's still a long other important issues, but in the interest of time, I think I'll wrap it up. Just one last query, actually. Just are you aware of any recommendations regarding the eCPR and what does it have a role here?
Yes, we basically eCPR has two role. One is during the CPR only we start with the we can start with ECMO, or after the patient has achieved ROSC and is in cardiogenic shock, refractory cardiogenic shock, then there's another role of eCPR. So
Yeah, so it's going to be VA ECMO, right?
VA ECMO.
Yeah. Yeah. So now they say in an appropriate setting, if you have the resources, the patient can go into eCPR and this kind of can be inserted in time, right? So I think we have covered. Yeah. Are there any questions from the audience? I guess.
So there was role of EEG. Somebody's asked.
Yeah.
So Dr. Jitin, you want to answer?
Yeah, I think we've already mentioned that if EG and seizure prophylaxis is very important. I mean, you don't give prophylaxis, but seizures are associated with very poor prognosis. So you need to treat them definitely aggressively, right? So if you have the facility of a continuous EEG that we have in our ICU setup, then definitely it can help. But otherwise, intermittently also you can have EEG done for longer durations if possible, right? And if you have any evidence of any seizure, right, or if there is something called as ictal syndrome, then probably there's an indication for that for a trial of anti-epileptics as well. Definitely, there's that. And the non-sedating anti-epileptics are indicated in these scenarios, right?
Can you please suggest where you referred regarding trials of TTM? So
Naba?
There is like all the basically sites. There's one app called ICU Trial. There you'll get all the like common ICU trials. Also in you can just simply search in Google, and also bottom line. Everywhere you can just mention TTM trials and you will get.
Yeah, you get the list of trials that are there, right?
I think that covers. Should we counsel about organ donation? What is appropriate timing for coordinating?
So after day 5, if the patient is not responding, and if we do the basically brainstem function test, and basically that is the time. If the patient does not, if we declare the patient as brainstem dead, then side by side we need to start prognosticating and discussing organ donation with the relatives.
Right. That is only in the setting of a brain death patient, right?
Mm.
So that is again a catch, right? Okay. Now again, important question: how early tracheostomy can be done in these patients? So
So the definition of early is varied in various studies. So the landmark trial that we have is the Trekman trial, where their early definition was within 4 days of in mechanical ventilation, and late was more than 10 days. But they did not find any benefit with early tracheostomy. Only thing that they found was there was less use of sedation in the early group, and so within a week.
So in this case, there is a little difference. First you have to really stabilize, prognosticate, and then really assess whether the patient is breathing. Talk to the relatives. Once you have told them, counsel them, do you really want to be aggressive? Understanding the prognostication. So they have a free will. So this is a little different scenario post cardiac arrest, not the routine one, NABA, where you have told. So this is where you
Yeah.
have to really talk to the relatives, discuss with them. Let them sink. This has to sink. The patient may not recover. So once everything is clear with the due consent, within 10 days, as we do, give them time, to really understand that it's not going to benefit them. The outcome is not going to be benefited. So it's their free will whenever they want. Usually within 10 days, we would prefer. Sooner the better. What about fluids? Fluids are routine, how you give to any critical care patient and knowing the cardiac background. No specific guidelines for hypoxic patients.
Just individualized based
Yeah.
on the cases.
Yeah.
So I think it's 12 to 30.
Yeah, it's almost done.
So we can conclude, Dr. Jitin.
Yeah, I think we should conclude just by mentioning few very key important points. Like there is a role of eCPR now that has emerged. If near future that may be case, and again we are moving from a targeted temperature management to a temperature control strategy that is there, and definitely seizures needs to be prevented. That if you're looking for good outcome, and uh, time to time assessment of your patient is equally important. Neurological assessment is very important, right? And finally, the neuroprognostication part is very important, and that you have to do after a period of 72 hours. So I think we highlight all the important points. One, the students should go and read about it. It's a very important topic, what we face on a daily basis in our ICUs, I think. So I think I should conclude here. Dr.
Yeah.
Warwick, please.
Thank you. Yeah, thank you. I think we will conclude here.
Thank you, Namba. I think if you should conclude now. Yeah.
Thanks, Dr. Jitin. Thank you.
So much, sir. Thank you so much, ma'am. And thank you all attendees to being here. Thank you once again.
Yeah.